musculoskeletal system. As we all know, this comprises both muscles and bones, and pathology that is associated with it. This is not to say that this is a comprehensive pathology presentation, but this is just some of the more probable things that you could actually have. So basically, I just wanted you to see what the internal structure of bone is. You know, we often forget that bone is is an organism in itself, as well as all the other cells in the body. You know, bone is constantly being broke down and then needing to be built back up again. And so, because of that, we have this cross-sectional portion here where we can actually see the vessels going through the bones and things like that. So it's very important that we understand that bones are not just some hard material that doesn't require anything. So that brings us to our first topic, and this is osteosarcoma. The first thing that you need to know about osteosarcoma is that it is the most common malignant bone tumor. So this is a cancerous type of growth, and the scary thing is that it can occur in any bone. So there's really no limitations on where an osteosarcoma can occur. And however, it usually occurs near the metaphyseal growth plates. So, or you may hear epiphyseal, things like that, growth plates, and that is simply where they normally occur. However, you can imagine the problems with this is because if this occurs at a very young age and it goes into the growth plates, it can cause very abnormal growths in bone, or extremities being shorter, things like that. So it can be very disruptive. It's thought to arise from the primitive mesenchymal bone-forming cells. So it is thought to occur from bone-forming cells that somehow become malignant in nature. Tumor consists of osteoblasts, which are bone-forming cells. You need to know that there are osteoclasts and osteoblasts. Osteoblasts form bone. Osteoclasts, on the other hand, are in charge of breaking bone down. So, as we can see, because it's produced by bone-forming cells, it would not be unheard of to assume that you're going to see a lot of bone growth simply because of what is causing this malignant tumor. It produced osteoid and spicules of calcified bone, and so we'll see what that looks like in just a few seconds. Usually metastasizes to the lung, and so that's going to be a common place to look. If you were to see an osteosarcoma, usually you will follow that up by doing a scan of the lungs just to see whether there's anything to be worried about in the lungs. In the United States, the incidence of occurrence is around 400 per 1 million. So even though it's the most common malignant bone tumor, it's still got kind of poor odds here. So as we can see, this is still a very slim chance per 1 million people. So not everyone is going to be affected by osteosarcoma. Most common sites are the femur, which is 42%, and most are distally. So it means that most are down towards the knee. And I think some of our images that we'll see are really focusing on the knee. Others are the tibia, which is 19%, and the humerus 10%. But notice that the tibia and the humerus are all proximally. So the tibia is going to be located still around the knee, and the humerus is going to be located near the shoulder. However, other locations are the skull, the jaw, and even the pelvis. All of these can be a result of osteosarcoma. So, what causes osteosarcoma? Rapid bone growth, as we see in the adolescent growth or adolescent growth spurt, when height just kind of takes off all of a sudden. That is one of the things that are thought to cause it. Also, environmental exposure such as radiation. We really don't understand what the linkage could be there, but it's a possibility. Also, genetic predisposition, such things as bone dysplasias, things like that, which could potentially be caused by genetic predisposition, could also cause osteosarcoma. However, I often wondered with this if radiation exposure could cause genetic abnormalities, which then could cause osteosarcoma. So there's still a lot of research that has to be done into what actually is causing osteosarcomas. So the symptoms of an osteosarcoma are an increase in pain due to activity. However, the bad thing is that it often mimics sprains, arthritis, and growing pains. Remember that it can be caused by the adolescent growth spurt, which we all remember having growing pains. And so many times it often gets just kind of brushed aside because of what normal body functions are occurring. However, there can be a palpable mass. You see a deformity in the leg or in the area, and that could cause you to palpate it and then instantly know something's not right. A decrease in range of motion depending on where this is going. Remember, the tibia and the humerus all were proximal. So if you get into the joint space and if this goes into the joint space, you're not able to move your joint, then instantly you would have a decreased in range of motion. In addition, weight loss, which is a typical malignant mass symptom, and then anemia. All of this can be a symptom of an osteosarcoma. So how do you find an osteosarcoma? Lab tests are pretty much not useful. They're only useful in management of the disease to see how things are progressing. A plain film x-ray is usually sufficient initially to find this growth, and then CT can be ordered. CT is primarily utilized for biopsy, and we do find that MRI is more useful than CT. And the reason MRI is more useful than CT is because it can visualize soft tissue structures and muscles and tendons and things like that much better than CT can. And so to see how invasive this has actually become to the surrounding tissues would be very valuable. Also, a radionuclide bone scan to see how far the disease has progressed, where hot spots are, things like that. Generally, CT is not performed of the bone, but it's rather performed of the lungs, and that's because MRI has a higher diagnostic value in terms of looking at the bone, while CT can rapidly scan the lungs and do a very excellent job of demonstrating any pathology that might exist there. However, if you were to do a CT for an osteosarcoma, you would most normally find that the CT findings mirror the plain film findings. You're not going to see a whole lot more than what you would on just plain film. But if you were looking at it on CT, this is what you would see. A typical sunburst pattern. And the sunburst pattern will mirror what I just drew here. It's kind of a center with bony spicules extending out of the soft tissue, out into the soft tissue. And so you kind of think of dropping something in water, and if you were watching it under high-speed camera, where you could actually catch the moment of impact, how you would see water droplets splashing up. That's kind of what an osteosarcoma actually looks like. Also, look for Codman's triangle, which is the bowing of the periosteum with the formation of new bone underneath. And we'll see what that looks like as well. So here we have the tibia, and notice that we have the fibula, tibia on both sides. So this is fibula, and this is tibia. Based on the size, we are probably at the tibial plateau or slightly below that. And so we're at the more proximal tibia. And we see this area here. Notice how hazy it is. We should see clear defined borders like this tibia. However, we don't see that, and we see erosion here as well. And we see a defined border up until we get to this point, and then it becomes hazy and jagged. And this is the spicular type look that we would find for osteosarcoma. And so this could be argued that you might not have been able to detect this on plain film radiography. However, we don't have any plain films to compare this one to. Here is one on the jaw. And as you can see, it kind of has the center, and it's spreading from the center. And this just kind of rough appearance. Typically when you're doing volume rendering, you're going to see a nice smooth appearance for the mandible, just like this. And notice when you get to this area, it all changes. And it goes smooth from here, but from this point to this point, we actually have no smoothness. It's all rough. And so it would probably be safe to assume that this patient could feel this in the mandible, and probably noticeable because of the amount of swelling caused in the soft tissues surrounding. Here's another one of the jaw, and as you can see, it has really kind of formed a large area. We actually have invasion inside of the mouth. We see that we have just the normal bone structure probably residing somewhere in here, but we have all this extra growth here. And so if you'll notice the patient's soft tissue here in comparison with the left side, we see that we have a large bowing effect here, and that would be very noticeable just by looking at yourself in the mirror. And so fairly obvious that something is wrong here. And this is typical osteosarcoma. Here we have another osteosarcoma. And notice that we have this possibly in some type of joint capsule, and we have the growth here, and we have extra growth out here. Let me refer back to this image for a second. We were talking about Codman's triangle, and what you would have for Codman's triangle is a bowing inward of the periosteum. It would look something like this, but then you'd have the bony growth like that, and so it would form a triangle. And so the periosteum would look something like this, and you almost see it kind of a bowing in here where the periosteum should be here. And so this would probably be defined as the Codman's triangle, simply because of the bowing in and then the filling in due to the osteosarcoma. And that brings us to liposarcoma, and this is a malignancy of fat cells. And so I definitely keep this in mind. and it is the most common soft tissue sarcoma. It appears as a slowly enlarging painless submucosal mass, and it's most common in middle-aged people. The average age of presentation is around 50 years old, and the overall 5-year survival rate is less than 50%. So the bad thing about this is most people consider fat cells to be just that, fat cells that you'll never have any problems other than just your weight. However, liposarcoma kind of breaks all of that down because it's a malignancy of fat cells. And not only is it a malignancy of fat cells, but it's ultimately quite deadly because we see that the 5-year survival rate is less than 50%. So this liposarcoma is not something to sneeze at, but rather something to be taken very seriously. No one knows really what causes a liposarcoma. It's postulated that trauma could be a causation factor, such as an MVA, where you had severe soft tissue trauma and bruising and things like that. Possibly this could cause or trigger liposarcoma to be formed at some point in time. That's not to say that everyone who has trauma or blunt abdominal trauma will have a liposarcoma. So that's why it's really unknown what causes it. So the symptoms of a liposarcoma is quite frightening because there is no symptoms until the tumor has enlarged itself. Until the tumor becomes large enough itself to cause problems, there's really nothing that actually happens. Possible displays after the tumor has enlarged itself are painful swelling, a decreased range of motion, numbness, enlargement of varicose veins, fatigue, weight loss, nausea, and vomiting. But if you'll notice, all of these symptoms are pretty generic. And so there is nothing to really say, well, if you've got this person has a liposarcoma. Rather, it's one of those things that's kind of stumbled upon. So the workup for diagnosis is CT, MRI, and an open biopsy. And what we mean by an open biopsy typically is them cutting the patient open and taking a biopsy of this for removal. However, based on new technology, CT offers an excellent way of biopsying liposarcomas and very accurate. And so CT biopsy has actually probably taken a great precedence over open biopsy. So you can pencil in here CT biopsy. So what you're going to look for a liposarcoma is an enhancing, solid, and homogeneous, poorly defined, infiltrating mass. A mixed pattern tumor with foci of fat interspersed in high attenuating tissue, and a pseudocystic water density tumor. And so I know that's a lot of big words, and so let's break it down. An enhancing solid, so it's going to have the appearance potentially of being solid, and inhomogeneous, so it's not going to have all of the same density on the inside though. And it's going to be poorly defined infiltrating. And what we mean by poorly defined infiltrating is it looks like it's spreading into the other tissues. It's like it has progressed into other areas, so it's very hard to kind of distinguish. Or we're going to look for fat interspersed in high attenuating tissue, and we'll see that in some of our images. So here we have a large, what looks to be somewhat solid mass with a little heterogeneous attenuation inside of it. But notice that we have this entire area. So we would define that this is the entire area, and we have what looks to be fat with a mass on the inside of it, and it's kind of fat is interspersed in this mass. And based on the location, It could either be humerus or femur. The bone looks a little small to be the femur, so very well could be the humerus that you're seeing this. Here is liposarcoma, that is an abdominal mass, and here you can see the entire border. And notice you have different attenuation factors on the inside. You have all these areas that I'm kind of circling that are less dense. And the reason we can say that they're less dense is because the grayer to black that something gets, we have almost the same density as air. And notice that this other tissue is much higher than density. It has a greater attenuation factor in it. So this is classic liposarcoma. Notice how it has grown and enlarged itself to the point where it's caused, or what looks to be caused, the bowels to kind of compress themselves. Notice your transverse colon here. And notice how compressed it is. And so this patient was probably presenting with abdominal pain or inability to actually defecate. So this is something very, very scary. Here is a liposarcoma of a patient's femur. And so we have a comparison view. So we have basically right and left. And here we see what a normal tissue should look like. And here we have the liposarcoma. And notice how it has this stringy, fatty appearance with septations and other things on the inside. And so that is typical of a liposarcoma. This is classic presentation. Here's another liposarcoma. And I'm not even sure if I've circled everything on this. We can still see it on an additional image. Probably this as well. We don't really know what this is attached to the kidney. But we do see that we have a liposarcoma. Okay, so that brings us to a synovial cell sarcoma. It's the third most common soft tissue tumor in adolescence, and approximately 1 in 3 cases occur in the first 2 decades of life. The mean patient age is 30 years of age, and it's not associated with synovial joints. It begins as a small nodule at first, which then grows in a short period of time. It is malignant, but generally has a survival rate of greater than 50% at 5 years. So let's put at 5 years. However, this depends on the ability of surgical resection. If surgical resection can be completed, then prognosis is good. So, what causes a synovial cell sarcoma? It's thought to be the translocation between chromosome X and chromosome 18, and this is thought to occur in more than 90% of all cases. So this is found a common thread, and because of this common thread, they pretty much know that this is what causes. So the associated symptoms are a small nodule that increases rapidly in size. Can be very painful and deep. You can also have tenderness in the affected region, and it's most common around the knee. Generally, plain film x-rays are utilized just as a precautionary measure to rule out a suspected fracture. And then if no fracture is demonstrated, then CT and MRI can be utilized. However, MRI does a much better job to demonstrate the soft tissue structures that are involved. That's why we favor MRI for things like this, because soft tissue imaging becomes very important, and it's something that MRI does extremely well. Also, genetic testing to see if this translocation between chromosome X and chromosome 18 actually does occur in your child. So all of these things will do an accurate method for diagnosing patients. So what it looks like in terms of CT is very similar to those on plain film. You have soft tissue mass with calcifications projected into it, and it resembles a snowstorm appearance with calcifications scattered throughout. So that's what you're typically going to look for, is the snowstorm appearance, and it will make more sense when we actually see an image. This image really demonstrates the snowstorm effect. As you can see, you have an enlargement here in the femur, and we can really see that in comparison to the right side. However, on the left side, we do see that we have this mass. We see that we have incomplete calcification of this mass throughout. We have these areas here, and this is what mirrors a snowstorm type of effect. And actually, I need to draw on down here because this is where the mass extends, and we do even have some calcifications on down. Okay, this is what it looks like in terms of MRI. You can see this area here. And notice the appearance that it has. Perhaps the single greatest type of musculoskeletal abnormalities that you'll run into is osteoporosis. It's something that you'll probably find on a large majority of your patients, and something that will cause great musculoskeletal abnormalities as well. Osteoporosis, for the most part, is a systematic skeletal disease characterized by low bone mass. It's also characterized by microarchitectural deterioration of bone tissue, and the ultimate problem with osteoporosis is that it results in an increased bone fragility, leading to fractures without considerable trauma. You'll see this many times over, that patients do absolutely nothing but ultimately wind up with fractures. It's considered to be a silent thief, which does not become apparent until a fracture occurs. We've done a better job of diagnosing osteoporosis nowadays, but we still are working on trying to find supplements that will reverse the cycle. But many years ago, it was considered a silent thief because patients never knew that they were losing bone mass until they broke something, and many times it was a horrible fracture. The most common metabolic bone disease in the United States is osteoporosis, and so it's very, very common, and it can affect almost the entire skeleton. So there's really no limits on where osteoporosis can go. As we've established before, bone is a living, constantly changing tissue. It is constantly being broken down and needing to be built back up. And as we saw before, that's accomplished by the use of osteoclast and osteoblast. Osteoclast breaking things down, and osteoblast building it back up. And what we're talking about here is bones, building bones back up and breaking bones down. The body establishes a balance between the osteoclast and osteoblast. And so you're hopefully, or you're striving for an equilibrium that exists between the osteoclast breaking the bone down and the osteoblast replenishing it. And so as long as there's a balance, things are looking fine. However, when osteoporosis occurs, there's more osteoclast than osteoblast. In short, it means that there's more bone being broken down than bone being replenished. And so that's why we have significant loss of bone mass. Risk factors include advanced age, something that we all know, female sex, family history of osteoporosis, thin build, early menopause, postmenopausal state, physical inactivity, the use of drugs, and calcium deficiency. And I'm sure we each saw all these risk factors actually come in play. One of the big things is physical inactivity. For example, if you were to fracture a leg and you weren't able to actually move that leg, it was just a stationary extremity for several months, then you would see a noticeable change between the two legs if you did a comparison, simply because of the reduced physical activity for one leg. Once again, there are no symptoms of osteoporosis until a fracture occurs. That's why it's called a silent thief, because you never know you have it until you do something wrong. So the workup for diagnosis is lab tests to look for secondary causes. Additionally, plain film x-rays can be utilized to look for fractures. If a suspected fracture is thought to occur, DEXA has been the thing that everything has kind of gravitated towards, because it is very reliable and yields constant, accurate results, and can be accomplished in a very short amount of time. However, CT used to be used. Some facilities still use it, QCT, but it's not widely used now, to kind of demonstrate whether the patient has lost significant amounts of bone mass. And then, for the most extreme cases, biopsy can be performed to evaluate the state of the bones. However, DEXA has kind of eliminated everything, and now is the go-to method for diagnosing osteoporosis and following that prognosis. So what you're going to be looking for in terms of osteoporosis on CT is just a generalized lack of bone density. As we can see, this is bone windows, and everything appears grayer or more gray than what typically would. However, you can see that in the vertebral bodies, there is a significant amount of dark gray, which should not be. It should be more along the lines of white. And another thing that we can assume is that we have compression fractures of both L1 and T12. I noticed the loss of vertebral body height, and so that's what we're seeing here. And notice this kind of bowing effect. But it's typically a sign of advanced age. Then we do have all of this stuff on L5, L4, and so this is just a classical representation of osteoporosis. Here's another example. Notice how you can see the outlines of the bones very well, but the insides are very, very light. But this is kind of a crazy thing. See this line running through here? This is due to heavy trauma. This is a fracture. The squiggly line running through. Okay. Here you can see, once again, osteoporosis. We know that this patient probably has advanced age because we have calcifications in the aorta here and here. And we do have in one of the common iliac arteries tons of calcifications. Also, we do have loss of bone density in the vertebral bodies. I notice we don't even really see much of any density here. Additionally, we have L5, 4, 3, 2, 1, 12, 11, 10, 9, 8, 7, 6, 5, 4, 3, 2. So we've got abnormalities at T11, probably T12 as well. Some at T4. We have vacuum phenomenon at all of the lumbar levels, with the exception of L1 to T12. And we have just generalized lack of density in the vertebral bodies. That is typical signs of osteoporosis. That brings us to rheumatoid arthritis. Rheumatoid arthritis is an inflammatory disease that causes persistent symmetric polyarthritis that affects the hands and feet. Typically, the small joints of the hands and feet are affected in a relatively symmetric distribution. The first thing that is most prominently affected is the metacarpal phalangeal joints of the hands, then the wrist, the proximal interphalangeal joints, knees, metatarsal phalangeal joint in the feet, shoulder, ankle, cervical spine, hip, elbow, and TMJ. All of these areas can be affected by rheumatoid arthritis. But notice that you're looking for a symmetric distribution. Usually, rheumatoid arthritis begins as an inflammation of the synovial membrane that lines the joints. As the inflammation progresses, the synovium thickens and erosion of the articular cartilage occurs. So what really is the result of rheumatoid arthritis is erosion of the articular cartilage. And because of this erosion, fusion across joint surfaces occur, as well as inflammation of ligaments. So because there is no articular cartilage, then fusion occurs. And then this leads to crippling deformities that we have probably all seen. The annual incidence of rheumatoid arthritis is approximately 3 per 10,000. And if you'll notice, that is a very, very high prognosis. However, we also see that rheumatoid arthritis, the incidence of the disease increases with age and peaks between the ages of 35 and 50. So, because of increasing age, we see that many times this is the area in which of life in which this starts taking effect. And it's interesting that women are 3 times more likely to develop rheumatoid arthritis than men are. So it's less common in men than it is in women. The exact cause of rheumatoid arthritis is unknown. We don't know why this inflammation occurs and then it breaks down the articular cartilage. We really don't understand. But possible causes are genetic, environmental, hormonal, immunological, and infectious diseases. All these has possible attributes that could cause rheumatoid arthritis. However, there's a strong belief that genetics do play an important role. So what occurs when you have rheumatoid arthritis? You can have difficulty performing daily activities, fever, malaise, joint pain, weakness, joint swelling and inflammation, joint stiffness, and even a limited range of motion. I think this is the most probable of the limited range of motion. I think that's something that we all see in patients who have rheumatoid arthritis, how difficult it is to actually accomplish just normal daily tasks. Even something as simple as putting on your shoes or tying your shoelaces becomes a long excursion just to get to completion. So how do you find rheumatoid arthritis? Well, a lab test can be an excellent way to start. You can have a erythrocyte sedimentation rate, C-reactive protein, and a rheumatoid factor assay. And so basically what all this is going to do is demonstrate whether it seems like rheumatoid arthritis is occurring in your blood or not. C-reactive protein is ideal for demonstrating inflammation. So this can be defined as the inflammation that initially causes rheumatoid arthritis. Plain film X-ray, just to kind of see how the joints are doing, whether they're becoming fused. MRI, ultrasound, and joint aspiration. Notice that CT doesn't play an important role in rheumatoid arthritis, but it's essential that we know what it looks like. And for rheumatoid arthritis, the earliest sign in terms of CT is soft tissue swelling. As the disease progresses, articular cartilage destruction causes narrowing of joint spaces. And you're going to want to, you're looking for narrowing of joint spaces, usually in a symmetrical distribution. So here we have rheumatoid arthritis. Notice how you have this bony growth and what looks to be fusion here. That is rheumatoid arthritis. Not to be confused with osteoarthritis. The most common type of joint disease is osteoarthritis. It is characterized by the loss of joint cartilage and reactive new bone formation. Sometimes it's called degenerative joint disease, and it affects over 20 million people in the United States as we speak. It affects more than half of the people older than 65 in the United States, and it predominantly involves the weight-bearing joints such as knees, hips, cervical, and lumbar spine. So we see that osteoarthritis is affecting those areas where weight is being borne, and rheumatoid arthritis kind of affects the non-weight-bearing portions of the body. Here we have an illustration of osteoarthritis, and notice that this is not in a weight-bearing portion of the body. So we know that in the hands it's more common for rheumatoid arthritis, but we do see that the joints, the interphalangeal joints have become very inflamed, and as we can see, they kind of look enlarged, and so we can kind of see it ballooning out here. That's kind of typical for osteoarthritis, although rheumatoid is much more common for the hands. So what causes osteoarthritis? While we don't know what causes rheumatoid, we do think that daily wear and tear are thought to predispose someone to osteoarthritis. Things such as age, obesity, trauma, genetics, sex hormones, muscle weaknesses, infection, rheumatoid arthritis, and bone disorders can all predispose someone to encountering rheumatoid as well. So what happens in terms of symptoms for osteoarthritis? You can have pain that's deep and achy, a reduced range of motion, and stiffness after rest. Okay, so the workup for diagnosis for osteoarthritis, number one could be plain film X-ray, just to kind of see how the joints actually are faring. MRI and CT. We see that CT is less accurate than MRI, and it's actually rarely used because MRI has better differentiation for the soft tissue abnormalities, and so we see that MRI would be better and more widely used than CT. However, if you're looking for CT, we find that CT findings mirror plain film X-rays. Early signs show narrowing of joint spaces with the development of bone spurs. As we saw in rheumatoid arthritis, symmetrical means a whole lot. Narrowing of joint spaces in a symmetrical fashion would be characteristic of rheumatoid arthritis. However, if they're not symmetrical, it would be osteoarthritis typically. And they will look irregular. For example, if you have a person's hip joint, let's say, you may see narrowing here, slight narrowing here. And so you may have higher degree of narrowing there. And that's typical of osteoarthritis. The greatest narrowing will occur at the point of greatest weight bearing. And so, as we saw, potentially one of the things that causes osteoarthritis is just simple wear and tear on the body. So it's going to make sense that the greatest narrowing or the greatest amount of osteoarthritis is going to occur where the body bears the weight the most. So here we see some osteoarthritis in the hips. We see it kind of bilaterally. However, we do see the right hip being more involved. We see that we have some space here, tons of space here, and then not much space here. There's tons of space, and it's characteristic of osteoarthritis because it's not symmetrical in terms of joint narrowing. Here's a better differentiation. We'll kind of bypass both this figure and this figure and kind of look for this one. We can see this area here, and we see typical joint space, and then we have this huge area, and then we have no joint space. And so that is typical of osteoarthritis. However, if you were to see someone and they had nice, smooth, even joint spaces, or they had the same amount of narrowing all the way through, then that would be characteristic of rheumatoid arthritis. Here we can see osteoarthritis versus rheumatoid arthritis. So as we can see, the rheumatoid arthritis, the joint lining becomes inflamed, which attributes to the arthritis, where osteoarthritis kind of develops bone spurs all along to decrease the amount of joint narrowing. That brings us to fibrous dysplasia. This is a skeletal developmental anomaly of the bone-forming mesenchyma. It manifests itself as a defect in osteoblastic differentiation and maturation. It's displayed as a scar-like tissue where normal bone should be, such as when fibrous tissue invades the medullary cavity. It can be localized to a single bone, which is monostotic, or found in multiple bones, which is polystotic. It represents about 5% of benign bone lesions, and it usually appears during periods of bone growth. So it would be easy to assume during adolescence would be the most present time because of the amount of bone growth that would be occurring here. But notice that it is a benign bone lesion, so the prognosis is not as morbid as some of the other diseases that we've actually looked at. This is a sign that can be on the skin. It's often indicative of a fibrous dysplasia. So a mark that looks like this on the skin often carries along with it fibrous dysplasia. So for monostotic fibrous dysplasia, we have it in several areas. Typically it occurs in the cranium, in the humerus, ribs, femur, and the tibia. So let's go through that again. Monostotic fibrous dysplasia usually occurs in the cranium, humerus, ribs, femur, and tibia. Each of these are common sites for monostotic dysplasia. It's believed to be related to a genetic abnormality on chromosome 20. However, it's not inherited from the parents. And so, potentially, simply because your parents have this does not mean that you would, or vice versa. Symptoms typically develop during the teen years, and remember we said that it's during periods of abnormal bone growth or rapid bone growth, and that's best represented in the teen years. Typical symptoms include bone pain, difficulty walking, bone deformities, and even fractures. Each of these can be a symptom of fibrous dysplasias. So the way or the route of diagnosis initially is plain film X-ray. It's usually the first method of indication, and then from there CT and MRI are both used. What you're looking for is, number one, ground glass opacities. Number two, homogeneously sclerotic. 21% is cystic. You're looking for well-defined borders and an expansion of bone with intact overlying bone. So we'll see what this looks like. So here we see what it looks like on just plain X-ray, being sclerotic. Just has all of these areas where there's lack of density all the way through, and we would say that, well, this patient has osteoporosis. However, look at how old the patient is. Also notice how femoral neck is angled in an entirely opposite direction, and notice how you have ballooning of the leg. Here is a skull that has this on it. And we see that it's pretty much all over. So here is what it looks like in terms of a volume rendering portion of CT. This would be the normal area, and this would be the affected area. And notice how much larger the right side has become versus the left. And notice these little areas here and here. This is all of what fibrous dysplasia is. Here's potential fibrous dysplasia in terms of looking at the spine. We see that the spine typically looks like this, but there's something inside of it, decreasing the amount of bone and the bone matrices inside. And then we even extend it out into the lamina and the pedicles. And so this person could have pathological fracture simply because of the removal of osteoclast or osteoblast. Okay, Osteochondroma. It's the most common benign bone tumor. So that is something you definitely want to keep in mind, that it is the most common benign bone tumor. The WHO, or World Health Organization, defines it as a cartilage-capped bony projection on the external surface of a bone. It generally occurs in the epiphyseal region of the bone and projects laterally. So if this is your bone, it will project laterally. It must exhibit the cortex and medullary portion as a continuation of bone growth. So actually this is going to not have a differentiation between the two bones, but it's going to appear as just a bony growth. And it accounts for approximately 35% of benign bone tumors, and is commonly found in patients who are in their 20s. So it's not uncommon to find patients in their 20s having an osteochondroma. And so here we see a chart that kind of demonstrates to us patients ages. This would be 0 to 5 or 0 to 10, and this would be 10 to 20. And so as you can see, the highest majority are in their 20s in this area here. And notice that it's much more common in males than in females. And if we refer over here, we can see that the most common area is definitely the distal portion of the femur, followed closely by the proximal portion of the humerus. And notice that 93 patients had it around the tibial plateau, somewhere around the knees. So not uncommon. And as you increase in age throughout life, notice the rate or indices actually go down for the risk of osteochondroma. So what causes an osteochondroma? Honestly, we really don't know. We're still researching what could be the possible causation. The associated symptoms are pain, but more often than not, irritation of surrounding tendons. And so this is what causes the pain because of the irritation. Plain film x-rays are usually the modality of choice, simply because they are quick and very, very simple, and the majority of facilities can perform this. Ultrasound is also a very excellent modality. However, the problem with ultrasound is that sometimes it's not available depending on where you actually are, what hospital you go to, what time of the day. MRI and CT both can be utilized, MRI providing better differentiation of the soft tissue structures, while CT doesn't. But CT also allows a very quick imaging and open analysis very rapidly. So what you're going to look for is a projection extending laterally from the bone. It's a continuation of the bone matrix into this extension. So the bone just looks like it has decided to change course, and it's growing in this area as well. So here we have an osteochondroma. Notice how we have this ballooned area. This area would be the osteochondroma. However, notice that there is no differentiation on the inside of where this benign tumor actually begins. It just kind of balloons out, but you don't see any differentiation between mesenchyma in any of the structure. Here's what it looks like on CT. You can see that it just kind of comes out and looks just like an extension of the normal bone. Here is a CT in bone windows. I notice how the bone just continues growing out, and there is no periosteum to kind of close it off. So it doesn't look like it's just something that it has decided to grow on later, but it actually looks like part of this bone. And it has the normal bone matrix inside of it as well. But as you can see, it causes significant problems with the tendons and muscles on the inside. And so this can cause severe irritation and can be quite painful. So enchondromas. Enchondromas are benign intramedullary neoplasms of hyaline cartilage. Occurs mainly in the extremities, slow growing, but it does disrupt normal bone by erupting as a mixture of calcified and uncalcified hyaline cartilage. As the tumor grows, it causes thinning of the cortex, leading to a fracture with little trauma. So it's almost to the same extent that osteoporosis is, allowing very, very small amounts of trauma to occur and causing disastrous implications. It's relatively common, accounting for about 10% of benign osseous tumors. About half involve the hands and feet. So it's much more common in the hands and the feet. Generally found in children and young adults. Once again, probably could be triggered by rapid bone growth because of young adults. So typical sites for enchondromas are the shaft of the humerus, shaft of the radius and ulna, shaft of the femur, and shaft of the tibia and fibula. It's thought to arise from the growth plate remnants that are not reabsorbed and either persist or begin to grow in the medullary canal. Often, no symptoms are present until a fracture occurs at the site of the tumor. And once again, plain film X-ray is the modality of choice simply because it's readily available and can provide excellent initial diagnosis, whereas CT and MRI would take a greater amount of time, and not all facilities will be able to offer these services. The CT manifestations mirror the findings of plain film X-rays and are typically speckled calcifications within the bone matrix, arc-like or ring-like calcifications within the bone matrix, and decreased attenuation inside the bone in comparison with other bones. So here you can see an enchondroma. This is just plain film X-ray. You can see on the PA, the oblique and the lateral, you can see this area, and it just looks like it's growing on the inside of the bone, and it's where the bone is being replaced by hyaline cartilage. And the only thing that we can really see is that it's just not as dense as the other areas of the bone, and so it would take very little trauma to actually fracture this. Here's the speckled appearance. See it on plain film, and then we exacerbate this on MR, and as we can see, here it is on MRI. So it looks much more significant in terms of MRI than it does on plain film, and that's why MRI is an excellent modality to utilize for this. This is a CT of the fingers, and as you can see, this is typically what the fingers should look like. This is what the fingers should not look like, and you can see that there's excellent density inside of this finger. However, there's hardly no density outside of periosteum for this finger, and so it would be surmisable that very little trauma would induce a fracture for this finger. Here is the speculation for CT. There's bone spicules, and the bone looks almost less dense than what it should on the inside, but these spicules kind of give it away. That's what you're looking for in terms of enchondroma. Okay, Ewing sarcoma. It is a primary malignant tumor arising in the bone marrow of long bones. So keep that in mind, it is from the bone marrow. A member of the Ewing tumor group, which all are believed to share the same type of cells. Primary occurs in the pelvis, femur, and trunk of the body. Peak incidence of occurrence is in the mid-teens, and it's rare in people over the age of 30. So you're looking kind of being out of the danger zone after the age of 30. Here we can see the typical sites of Ewing sarcoma being in the humerus, in the pelvis around the acetabulum area, femur, the tibia. So the less common sites are in the spine and cervical spine, scapula and ribs, lumbar spine, iliac crest as well as the sacrum, radius and ulna, and the fibula. All of these sites are less common, however this does not negate the possibility of them actually occurring there. And once again, like many of the things that we've discussed today, the cause of Ewing sarcoma really is not known. Typical symptoms are pain, palpable mass, back pain, fever, weight loss, and even metastatic disease. And the weight loss is pretty much an indication of metastatic disease, especially significant amounts of weight loss. So typically plain film x-ray will be utilized, and then CT, MRI, and biopsy. Usually the biopsy will occur through CT guided biopsy to get precise location and allow excellent samples to be taken of this sarcoma. So what you're looking for is a destruction of a portion of the shaft of the affected bone. It typically occurs in the midshaft of long bones. Destruction results in an onion skin appearance, and so we'll see what that means. Here we have, kind of in the wing of the pelvis, destruction of the bone. And what we mean by destruction of the bone is, notice we have normal bone coming in, normal bone going out. But we have nothing here. And that is bone being destroyed. So that's bone destruction or erosion there. Here we see potential start when compared to the left side. However, this is not quite as impressive as the previous image. Here's another kind of, this is the typical onion skin appearance. When you're thinking of onion skin, or when you're kind of pulling the skin off of an onion, and notice how the onion kind of falls apart, well, that's what you're looking for here, with this being pulled apart from normal bone. And notice this is in the tibia, and so we should see just a solid line running through here. However, what we do see is a gap here, and significant gap here. And so that's what you're typically looking for, is this onion skin type of appearance. Here's an MRI, and we have bony destruction of the skull here. And so we have the tumor actually growing here and actually invading inside of the skull as well. You don't see much of a midline shift. We might have compression of anterior horn of lateral ventricle, but not a whole lot, not an amount of shift that you would have thought. But typically what we're looking for is just bony erosion, in which we have a clear, definite portion here. So that brings us to bone metastasis. Bone metastasis is the most common malignant bone tumor, and it spreads by the means of the bloodstream or the lymphatic system. The most common primary tumors are from the breast, lung, prostate, kidney, and or thyroid. All of these will typically result in bone mets. Common sites of metastasis are the spine, pelvis, ribs, skull, proximal humerus, and femur. And so there are a lot of bones that can be affected. And notice 1, 2, 3 of these are significant weight-bearing bones. So it can cause a lot of abnormalities just simply from this. So here we have a scan and all the patient's hot spots. We have radionuclides in the bladder, but we do have a hot spot here, 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 here. And so if we'll notice, this is potentially all areas where the patient could have mets. Here's just a plain x-ray of what bone mets actually look like. As you can see, you have bony erosion here, and this is a very poor case because the bone mets are pretty much everywhere in the pelvic girdle, and even in the acetabulum, even in the femoral head, neck, and even shaft. So this is a very poor prognosis for this patient. In terms of CT, this is what bone mets typically would look like. Notice this is the ribs, and we have complete destruction as well as growth bilaterally. Here's another form of bone met. We see bony erosion here, with this being possibly the only amount of bone left. We also see an area here as well. We have an abnormal growth here, and we do see atrophy in here due to the fact of the pressure that is being put on the brain. Okay, this is one that I found. This is destructive bone mets in the right iliac. So we see this is typically the left side is what we would typically want to see. The right side is not what we want to. This is a bony mass which has caused destruction of the integral parts of the pelvis, and so it would be interesting to see whether this patient could even walk at this point in time based on the destruction of the pelvis. So that brings us to fractures. I think that it's very important that we look at fractures because many times you're going to be seeing it on CT as well as normal X-ray. So this is an incomplete fracture. As you can see, it fractures through the periosteum, but it doesn't go all the way through. Transverse fracture is just what the name implies. It is a transverse section. Oblique comes at an angle. Spiral does something like that, where it curves around. Comminuted is pretty much like a shattered type fracture. Avulsion, we all know, just a very small fracture. Butterfly fracture creates something like a triangle. Segmental divides it into segments. Green stick basically causes bowing as well as possibly an incomplete fracture. Torus causes these bony out sides. So here we can see that this patient has several fractures. Here, and the most obvious here. But also notice that there's something going on in the pelvis here, here. And so it can be argued whether this patient has osteoporosis or this patient does have bone mets. Here's another fracture. This is basically a spiral or oblique type, probably favoring more along the lines of oblique for the tibia, and possibly a spiral / comminuted for the fibula. Here is an intertrochanteric fracture. Notice that we have femoral head and neck. All of that is intact. However, we do see that we have femur here and nothing here. So this is probably an intertrochanteric fracture. Here is a fracture of the femoral head, which could possibly be a butterfly type fracture. Notice that we don't have any abnormalities in the acetabulum, and there doesn't appear to be any fractures. I don't believe that this is a fracture. If it is, it looks like it is actually healed. Here's a skull fracture, or multiple skull fractures. We have an area here, here, and so this is also demonstrated here. And I'm sure there was trauma associated with this patient all throughout the facial bones, but this is really all we get to see. But there are significant amounts of fractures here in the skull. Okay, on this image we have a rib fracture. Sometimes rib fractures are a little more difficult to really discern, but depending on what type of protocols we actually utilize and what type of window and leveling as well as volume rendering will really indicate potential fractures. This is a very severe fracture. We have here, here, and an intertrochanteric fracture. And based on the way that this hip is turned, there's still some questions whether the acetabulum will be fractured as well. Okay, here we have a radial fracture. That's not really displaced very much, but it's still a radial fracture. Here's a scaphoid fracture. Possibly an ulnar styloid fracture as well due to the amount of separation here. And that is it. Definitely be prepared to look for fractures on images, because I feel that's one of the things that sometimes we often overlook or don't do an excellent job of. So be prepared to look for fractures on your third exam. If you have any questions, just let me know at tmassengill0002 at kctcs.edu. Thanks.